My dear students, I record for you this lecture. So today we will speak about the thoracic part and examination of thoracic. So I do not need my face to be seen here for sure. Better to look on our presentation. I will share it with you right now. One moment, please, if I remember how it has been done. Okay. Okay, and once again, share. So now you can see all parts that will be shared with you. This is our presentation. So I will speak and explain portion which I need to be known through our examination. Once again, someone is entered our class. Who is it? I can chat here. Okay, no problem. Let's begin. So today we'll examine our patient by thoracic part and everything that we have inside. You remember that we had done cardiological examination when we spoke about the problems which can exist in the heart and vessels as well, yeah, and how to recognize and sign it in our history. Now maybe it can be done earlier, but it's not late right now to speak about it. We will speak about the lungs perfectly because the most important, one of the most important system in our body is expiratory. So expiration, changing of oxygen is very important to our body because without oxygen, it's no energy in our cells. Most cells have oxygenated biochemical reaction to use to choose to find out some energy for life. So that's why it's very important all disease which we have here. But when you see, and you see right now, okay, I will increase the size, thoracic part, you can see only the skin. Can you understand where and which part we have? In cause lungs and heart are very served by their structure and tissues, so it will be covered by the specific cage. There, it is inside the cage, which is done by our ribs and sternum bone here in the front part, clavicle as well, and vertebra from the posterior side. So this cage protect inner organ, soft organ, very important to our life organ like lungs, some specific vessels and lymphoid nodes as well, and heart, my dear, and part of gastrointestinal part like esophagus as well is behind the sternum bone. So let's continue. So what we have to check? We have to check some system, but always we begin with our examination by the first coming patient by our eyes. What we have to check? Thoracic part, like part of the body. We have to check skin at first, color of skin. You remember I repeated not once that color of skin give you information about 30% of the diseases which can be inside us. Why? Which kind of? Bacterial, of course. If we have problem with HEPA, like jaundice, yes, sure, so it will be a slightly yellowish color as well. Or if it is reddish, if it is pale and other kind of, it can be taken like heart diseases or problem with the blood system as well. Respiration exchanging as well give us decreasing of oxygen inside the red blood cells, which give you decreasing in the color. So pale color as well can be deoxygenated, like bluish on the peripheral or central parts. So first, skin and skin color. Then symmetry of the thoracic part will give you idea about the changing inside. So the most visual part is trauma, accident, or changing in the shape connected with the scoliosis. So 1 second, I will try to find this picture for you, and you will understand what about I'm speaking right now. Okay, I think this one. So look here. Here, different kind of, oh, not this one, my dear. Different kind of thoracic portion. So the first one is normal, and if we will cut our patient transverse, you remember which cutting is transverse? Horizontal kind of, yeah, so it will be oval. So it's not the same length in whites in the two examinations. So from anterior to posterior part it will be shortened than through the lateral one. So see, this is normal oval shape of the cutting and inside organ. But we have as well barrel chest. What's happened here? See, the sizes is almost the same. Almost, I do not say the normal. Normally, it must be the same. What information it gave us that lungs has more place for the organization than in the normal one. It's not pressed by the ribs, so maybe excursion of lungs will be less than in normal patient thorax. Understand? Yeah. So now look on this one, scoliosis. Of course, I do not say about the first and second stage of scoliosis. So one side is smaller than another. So inner part will be pressed by the bony structure here more than another. So excursion and changing of oxygen here will be less than another. So more inflammation will be in this part. Why? Because it cannot be opened fully, so it cannot be full blood streaming here. Here bacteria will grows and develop more than another part. So some recit perfectly changing in the young age will give you pectus carinatum, see here, as well as some heart diseases will give you this kind of rising part of sternum here. So it looks like heart which we are drawing perfectly, yeah, on the paper. So the same but different shape. If here is going out, here is pressed in pectus excavatum. So depression of the sternum bone as well will press on the specific organ like heart, and heart diseases can exist here, and lungs and lung diseases like severe pneumonia can be in this patient as well. And kyphosis, see, changing of the shape and the transverse cutting is given to you here. Understand? Yeah, so different shape of the thoracic part will give you difference in the diagnosis as well. And from the first view, you can get ideas that something inside will happen, and we have prescribed understanding and examination of this part to avoid any kind of problems and diagnosis in this patient. So, but because outer part is only skin and we have not x-rays in our eyes, we have to find new ways of examination. How we will find it? At first, we have to know where which organ lies. To be sure, it's something like this, some mass inside it. See, some part of this thoracic cage done by the rib cage, yes, by the ribs, is fulfilled with a hepa, liver, and a stomach part as well. They must be protected as well. They are software, but very important. That's why they are covered behind the ribs as well. So, in the beginning, we have to understand which rib where exists. All of you can find this outer superior part like clavicle, the most upper part, top of our thoracic part, and more the most going out parts. So if you will touch your shoulders and superior part of it, you will find out clavicle. So where clavicle is connected with the middle bone, which is named sternum, sure, this one, you will find this part. So check, follow this bone, and you find the first depression. See, below the clavicle is the first depression. So here begins the first rib. Why you have to calculate rib at first in the heart diseases, and I get this information to you. It's very important to find out the fifth intercostal space where you will find apex of the heart. You remember, for a specific procedure like a syringe or injection by the syringe of adrenaline, which can be done perfectly in the apex of the heart sometimes. Yeah, so here by calculating the rib and intercostal space, intercostal, it means between the cost, between the ribs. So the first intercostal is between the first and second rib, sure. So between the first and second, it's first intercostal. Between the second and third, second intercostal space, and so on. So by pressing the finger, you will find near the sternum excavation, depression, excavation, depression, excavation, depression. So you will find which rib you have here and which intercostal space. It must be done for sign for notice the space where the changing of sounds or changing of shape is in our patient. So it must be noticed here. So good news for you is that you do not do diagnosis, you only notice which changing you have here. So first, once again, skin, color of the skin. Second, shape of the body. Third is palpation. What is palpation, my dear? When you press your hand, if I have here a picture, I will show you. When you press finger, no, I haven't, but I have a lot of interesting portion here. So when you press your hands on the thoracic part and find out if something specific happens here. One moment, please. I will open the book, which you have to read here perfectly. Is portion of palpation you can see here. See, both hand is pressed on the back side of patient to compare these two parts. For sure, we'll do some specific maneuver here, which will be discussed later. But in the beginning, you have to get this information. So once again, which book you have to read? It's Bates perfectly. Is on the portal you have it uploaded. So from the 304, as I remember, and till the 400s, it's description of the lungs and examination of the thoracic parts. So when you speak with your patient, when you take some examination of your patient, of course you have to give some questions. Which kind of question must be taken to our patient to take information about the respiratory system? It's connected with the breathing. What is connected with the breathing? Is it important to give information about the diet? I think no, but information about the tobacco use must be taken from our patient. So it's given a lot of information about tobacco, about its bad and good sides for patient. If tobacco is good for nervous system and some Parkinson, Alzheimer diseases, it has a big stress on the respiratory system. So it's do harm for respiratory system. Which kind of? Oh, at first it's contraction of the vessel. So if vessels are contracted, here will be decreased exchanging oxygen with deoxygenation, blood as well. So the next is extra garbage or trash which is collected in the alveolus, and of course I will show you in 2 minutes what is alveolus and where this trash and particles of tobacco are increased and collected, excuse me. So you will ask your patient about tobacco use, and of course not only once experiment with tobacco is important to us. We have to know how many cigarettes per day or how many packs per day use our patient. So here is given like advice to quit. For sure, it's not so good idea to advise to quit to every patient. Why? Because using tobacco gave you two kind of problem. First is somatic and another is psychological. So both of them must be protected through the period of quitting, if I can say so. So you have to begin this problem with not to quit but decrease of using tobacco, and push part by part, step by step quit it, not once and fully. Step by step. Decreasing is better than quitting tobacco using. Okay, or it will be stress for our body, and it will give you kind of increasing of cancer in our patient by percentage and so on and so on. So other question will be where our patient works. So surrounding air which our patient used to embrace is very important to us by idea to do diagnosis. Sure, when patient is working with where he's working. Okay, excuse me, some now ring is coming. So when he is working somewhere in the fabric where is a lot of dust, and dust is not only silicates but other kind of chemicals as well, it can be collected in our lungs as well. Can you imagine if some silicates are collected, so it will be then mixed with some liquid which we have in our alveolus as well. So stone kind of portion will tissue will exist here. So, like small silicate stones which decrease the size where the exchange of oxygen happens. So, And this kind of disease and perfectly give us disease named silicosis. It's specific name for lungs destruction, if I will find it. Maybe it will be some picture. Okay, see my idea on this picture. This white part is perfectly silicate, and here is given inside the lung, inside the structure, small like sand kind of is inside. And if you will cut it, can I do it bigger? So this is fabric where is this dust? See my idea in the picture? And then it's collected in your lung. Come on, yeah, sure. It's lungs with silicosis, cotton, and shown for you. So sand is inside the alveolus, and here is no place for excursion and no place for exchanging of oxygen for oxygen as well. See, understand? Yes, how important it is to ask our patient about the silicosis and about this kind of diseases as well. So place where patient is working is very important to us as well. Let's go further. What we have. As well, you have to ask about the medication which your patient has or used to. Why? Because some of them decrease the bloodstream or change connection with the oxygen for our red blood cells or erythrocytes. Happens something like this. So you must notice all the drugs, all the medicine which your patient take in this period or earlier. Oh my God, I do it very fast. So, excuse me, my dear, I will use this one. So, once again, we speak about the thoracic part. We spoke about the changing of the skin and shape in the beginning, how to understand which rib you can reach and where perfectly is destruction of the inner organ, changing in the inner organ. So see, below the clavicle is the first rib. So the first depression after the rib near the sternum, or you will do mistake, my dear, near the sternum, near the middle bone is first intercostal space. So we will speak about the percussion and auscultation, and if you find something here, you will describe it like left side first intercostal space. Understand? So, or right side second intercostal. So, and you will calculate where perfectly it is. So then we will speak about the specific lines. Here is some lines which you have to know. First is at the sternum, perfectly on the both side. Second is C clavicle. Yes, you divide clavicle on the two parts and perfectly in the middle, it's midline, yeah? Then it's axilla. Axilla begins where your hand is connected with the thorax, so axillaris line as well. See this one? We will speak about it. I will show another picture for it. Why not? So backside, from backside, it's slightly more difficult to calculate where perfectly is rib, but you have here promotion of the spinosus processes, the most outgoing processes is from the seventh neck or cervical vertebra. Take your hand back on this part and you find this big not big, ball kind of excavation. So it's a spinosus processes of the cervical seventh vertebra perfectly. So below it will be the first thoracic one, yeah, by processes. So the first rib is connected with this first thoracic processes. So below the first rib will be the first intercostal spaces. So somehow we can understand where it is. Once again, from anterior part, it's clavicle. Clavicle connect with mid bone or sternum bone. At the side of the sternum bone, below the clavicle is first rib, and below the first intercostal space, and so on. You will calculate from the back side. Take hand on the spinosus processus of cervical seventh, and then below it will be the first thoracic vertebra which connected with the first rib. Understand? So to be sure, this is our scapula, yes, on the both side. In a normal thorax, normal body, the low portion covers the seventh rib and reach the eighth rib. So this is a landmark as well. Angle of scapula, the most low portion of the scapula, named angle of scapula, is flat bone, and you can reach it with your hand as well on the back side. Try to reach it. It's like triangle kind of. So the most low part of it, move your hand, and you find this angle, is reach the eighth rib and cover the seventh month. So seven rib, seven intercostal space, and eight rib perfectly. Here is the angle in normal. Why I say in the normal? Because in the scoliosis it can go slightly more low side or be slightly increased as well. It can change the position, so some changing exists as well. Okay, so once again, the lines. Can I make it bigger? I think yes. Come on. This book is in your on your portal, excuse me. So Bates, once again, perfect book, very interesting and very easy to read. For sure, it's easy and interesting to read. And of course, you do not need all diseases. You need examination of the patient right now. We will study diseases later, I think. So what I say is the middle bone is named sternum. So perfectly in the mid part of the sternum line, which goes from up down, will be named mid sternal line. Okay. Here will be sternal, right? Parasternal. Para, it means nearby, yeah? What I say, we have clavicle, which can be divided into two parts, and the middle line going on the scapula down will be named mid-clavicular line, where hand is connected with the thoracic part. See, my dear, here on the side of our thorax till the clavicle. Yeah, it's named axilla line, but axilla is from this part till the back side, all part where hand connected to the thorax. So which axilla? It's from anterior side, so anterior axilla line. I think it's easy to remember. Go down. Oh, that's why I say. So now raise your hand. You remember anterior axillar line? So the same will be from posterior side where your hand connected to the body. Going up, raise this line and you will take posterior, which mean back side posterior axillary line, and between them on the middle side you will divide this part on the two parts. In the midline you will take it and name it like mid axillary line, nothing else. Yes, mid axillary line. So what we have on the back side, we have vertebra in the middle side, so we name it vertebral line. So vertebral line is normal or abnormal in scoliosis, kyphosis, and so on. So scapula line, what we name, how we name scapula line. So divide perfectly, it must be middle side, so of the thorax. See, from vertebra till the lateral side, we divide on the two symmetrical parts, two parts the same sizes, and name this line scapula line. Okay, so inside this cage we have the respiratory system, which connected with trachea, nose in the beginning and mouth, then trachea, I will show you, then bronchus, which connected or continues by the lungs. So we have right and left lungs. What is interesting? The right lung consists from three lobes. So the last L, which you see here, is part of the word lobus. So right lobus, right lobus, right lobus. The middle letter, which you can find here, R-U-L. U means upper, up part. So this is right upper lobus, which is on the upper side here. So this is middle part. So middle, right middle lobus of the lung, right lower lobus. On the left side we have only upper part and low part. Here upper lobus and low lobus. Why here is another line? Because this is excursion. When you inspire, your lungs increase in size and going till this line. When you expire, it goes up and reach only this length, which is given by the rose color here. Okay. From the sides, how it looks like, my dear. Okay, now let's see what we have here. I say that inner organs lying very strange here. Let's find what we have here. So this is how we calculate. If we have problem here, we can recognize and sign it like right upper lobe for first intercostal space. Okay, you do not need to know all the portion, but where is the upper part, upper lobus, low lobus, or middle lobus, you can read here. So this is how lungs are here and HEPA part perfectly, and diaphragma. So what is diaphragma? Diaphragma is a specific sheet which differ organs in the thoracic part from organs in the abdominal part. So lungs and heart from HEPA, stomach, spleen, and intestine, which we have in the abdominal side. So, and as well its muscle, which by its contraction can increase size of the lungs, taking it down, pulling it down, or pushing up. So this part you see is diaphragm. By contraction, it became lower, and the lungs, because it's connected with diaphragm, will come down, and inspiration exists. Understand? So only by diaphragm. It's when diaphragm goes down, and when it's relaxed, it's takes its shape, concave shape, as you see. It's pressed on the lungs, and of course air from lungs is going to the trachea and then to our nose. So how it is, what I say, our respiratory system begins from the nose part, then and the mouth as well. It's two pathway for the ear. Then we have throat here, trachea, which divides on two main bronchos. Then bronchus divide on the bronchioles, smaller parts, and on the end of the bronchioles, see my dear, we have a lot of bubbles, which named alveoli, where perfectly exchanging of oxygen happens on inner epithelium of these alveolus. Here it must be given some idea about nowadays and about the COVID viral infection. It's said that viral pneumonia exists, and on the CAT, you know, this kind of examination, but X-ray, it's given like stages 6, 7, 8, 25. So what it means? It does not mean that alveoli are destroyed. No, perfectly tissue around the alveoli is swelled by the viral infection, not inside the alveoli, but on the outer parts. But in cause of swelling of it, alveoli are pressed by this liquid, extra liquid, which we have in the tissue, in the interstitial tissue in our lungs. So if this is parenchyma, the specific tissue which is used for respiration. So interstitial is additional tissue between these cells. Yeah, so it's swelling, it's pressed the alveoli from all sides, so it decreases size of alveoli by pressing of the swelling part. So what's happened? We do not have place for exchanging of oxygen. That's why in the COVID viral infection, pneumonia, we have desaturation, what means that we have decreasing of oxygenation of blood. Understand? So this is once again picture of our respiratory system. Understand? But when I say about the diaphragm, I say that the contraction of this muscle takes diaphragm down, and the lungs are following the diaphragm. How it happens? Around the diaphragm, around each lung, we have pleura, the specific tissue which covers this lung and protect it from the infection and trauma as well. But because we have negative pressure, we have no air and no spaces between the pleura and diaphragm. It follows, it sticks with diaphragm and follows diaphragm in the movement. So upper part of our lung stays on their position, and lower part follows the diaphragm, so it increases the size through the inspiration. Understand here? So now after this slight excurse in the inner part, in the respiration part, let's follow our books and see what we have to do. So we have to find out problems which happens in our lungs. In the beginning, we have to check trachea. What is trachea? Where is it, my dear? In my picture it's seen better. See, this middle part, on the middle part of your neck, you can check it with your hands. Took one hand, or better to take both of your hands, on the side of trachea, and follow it down till the thorax, till the sternum bone. It must be in the middle of your neck. When it changes the position, perfectly it can change position. When in lungs we have some destruction, some problem. See if one lung is collapsed. Can I do it bigger? One moment, dear, my dear. So, see. So the trachea can displace to the side of the collapse. This is normal lung. After trauma or some injury, we have collapse because what we say is the pleura covers the lung, protected from the trauma when we have some injury of this pleura. So some air goes in the thoracic part, pressure from outer side increase, and it's collapse of the lung tissue. It do not work right now. It is like a balloon without the air inside. But in cause here is difference of the pressure in the right and left side. Trachea change the position. Okay, as well in collapse lung or pneumothorax as well. See, traumatic pneumothorax as well will have changing in the position of the trachea. It goes to the affected side now. See? Okay. So that's why we checked trachea in the beginning, in the middle side of our body. Then after this examination, after trachea, we have to check the lungs and the bronchus. But it cannot be done because it's inside the rib cage. So now after palpation, and why we do palpation, but because sometimes you cannot see the deformation of the rib cage in cause patient can be so fat, and fat tissue covers the rib cage, and it's not seen properly the changing in the shape, or we have some scars inside, or we have some changing in the tissue like how to say it, changing in the tenderness as well. So it must be seen by your finger, by feeling of your hand. After it, you have to do percussion. Do you remember what is percussion and how to do it? Percussion is when you hit the finger of one hand, which lies on the thoracic part, with a finger from another hand. What you produce? You produce some sound. Normal, you do it, of course, on not on the bony structure, but between the bones in the intercostal spaces. Normal, you produce resonance sound. But if here is increase of resonance sounds or timpani or decrease of it, perfectly dullness, it gives you information about the diseases which we have in our inner organs. So dullness perfectly can be in consolidation or collapse. Stony dullness can be in pleural effusion. Hyperresonance or timpani is in pneumothorax. I will give you some short videos, you will understand it. So once again, what we have to do is for fun perfectly. You understand that we cannot check our patient through the tissue. It will give you changing in the sounds. So after percussion, you will do auscultation. Auscultation and percussion must be done on the specific lines. So on anterior side, it's parasternal side. See, my dear, it's given in the picture. And on the posterior side, it's between the vertebra and scapula because scapula bone can change the sound. So we never do auscultation or percussion on the bony structure, only on the intercostal spaces. What is the first we do in this fossa? You remember where our lungs are, see? Lungs reach this fossa. So when you do auscultation, perfect auscultation of these parts, you will find out the most upper parts or apex of the lungs. Understand? On the both sides, because they reach this part, and here is only soft tissue and the soft fossa, and you can perfectly get information about the sounds and changing of the sounds inside the organ. So, percussion and auscultation must be done, and it does not matter which you begin and which you continue. First is percussion or first is auscultation, but done on the specific side. Only one interesting side that you use diaphragm by auscultation of our stethoscope. Look on the hand how we took our diaphragm, press firmly on the skin, or if it will not be pressed firmly, so sound between the diaphragm and skin exists, and by mistake you can take it like long sounds. How we do it on the posterior side? It must be done symmetrical. 1, 1, 2, 2, 3, 3, 4, 4 to compare the sounds on the both sides. The same for the percussion. When you do percussion, you have to compare. Do one on the one side, then on another to compare the sounds between them. So, about the sound and about the percussion. You will do on the both side once again. See? Once again, what is percussion? Taping of a normal air-filled lung should produce a resonant percussion note. On the contrary, percussion of a solid tissue, such as the liver or the heart, should produce dull note. And percussion over hollow spaces like Traube spaces, and we will speak about it in abdominal examination, should yield a tympanic note, which is a drum-like sound. When you auscultate, you have to compare the sounds perfectly. And I will give you right now all the sounds, my dear. Perfectly, it's normal sound, bronchial or vesicular. On the bronchial part, it must be bronchial. Where we have alveoles, it will be vesicular sound, but it can be changed like rails, small clicking, bubbling, or rattling sound in the lung, ronky sounds that resemble snoring, stridor and wheeze like sound hard when a person breathing, and wheezing high-pitched sound produced by narrowed airways. Now let's see some videos, and after we'll speak about it.
Grammarly does more than catch errors. With Grammarly, you can find really good. Hey everyone, welcome to our video on lung sounds. This is a collection of lung sounds that we have in the library at our website, entprep.com. We are excited to offer these to you.
I can show you on the patient, so let's listen carefully which kind of sound exists. It's bronchial breath. It's normal bronchial breath, my dear. Now it will be crackles.
ვიცი გილზასთან უფრო გარკვევთ რაღაცა 9-12-ში გაწერილი მაქვს პორტალზე და 12-12-ში არის ისტორია, ის გამერკვიეთ რა იქ ის ისტორია მინდა თქვა. ის ფორმაცია თუ შეძლებთ ახლა გააკეთეთ საჩი და
This is traitor, my dear. By auscultation, you will find out. And this is vesicular breath sound, my dear. Normally, sounds is the last part where the alveoles exist. Find out, yes, difference. So you have to notice what kind of sound you find and notice where perfectly it is.
Hey everyone.
In which part perfectly you find this kind of sounds. So it's not difficult, my dear, to find out. Let's see next our video. Now you understand what is difference in the sounds. I will show you 2 videos how to examine patient and one for percussion, how must it be done perfectly. Unfortunately, I cannot show you some way on the patient, so I will do it here by these specific videos to you.
I have to stop and tell you guys about
how I hate this.
Lecturio.
Hi there, my name's Andrew, one of the final year medical students. Could I just check your name and date of birth, please?
Sure, it's James Alexander, 13th of December 1989.
Nice to meet you, James. Today I've been asked to examine your chest.
You ask your patients, yes, you take some question to your patient, and of course you explain what you have to do with your patient.
Pain anywhere at all. Have you any questions about the exam? No, I don't. Okay, James, we can start the exam now. I'm just going to start by having a look from the end of the bed.
What you are looking for? Is it some changing in the color, shape as well? Yeah, remember? We do not discuss about it, but it's about the cyanosis and about the changing in color and shape of the fingers as well.
Fantastic. And if you could bring two fingernails together like this for me.
Clubbing of the nails as well.
And again, if you could just bring your arms out in front of you. I'm just going to assess the temperature of your arms.
So temperature of the skin as well is very important. You remember it's bloodstream which is going here. Tremor of the hands as well must be checked.
And cock your wrist back, James, and keep them there.
See how it's different. So normally your hand is not stressed here. You remember about the pulses, but we do not need these pulses here. As well, we do not need this angle. It will be checked in the cardiovascular system.
I'm now going to pull down on your lower eyelid.
Eyelid for anemia or decreasing or changing. Mouth, of course, if we have any problem like bacteria here.
I'd now like to more closely inspect the chest.
Deformities and scars.
You just lift your right arm up for me. And your left
So
arm.
sometimes patients forget about some
I'm
surgeries
just going
that
to feel the position of your windpipe.
has been done. Yes, so then trachea, is it in the middle side? And nodules nearby. Palpate. Heart beating, apex of the heart as well. You remember we do it?
I'm now going to assess the expansion of the chest. So
And
just
now
above
is
this
portion
around
which
the
I
chest.
do not describe because it's strange to discuss about this without patient. So excursion of the lungs. When you inspire and expire, your thoracic part change the shape there. This changing must be checked by your hand. It must be symmetrical at first. It must go the same time and no problem exists. Look, my dear, he will show you right now.
Quite tightly, then asking you to take a deep breath in.
He will take hands on the chest, see? Take the fingers in the middle part. When he expire, his big fingers are going separate, but from the midline, it is symmetrical.
I would now like to tap on
So both part of the chest is involved in the process of the expiration. And this is percussion. What I say, we begin from the apex of this fossa, where the top of our lungs or apex of the lungs exist. Yeah. Oh my God, excuse me. It's my fault. Listen to the sound. He compare. Please try to do it at home. Not only on the lungs, you can do it on any subject.
James, I'm now going to listen to the chest. You can just take some deep breaths in and out through your mouth.
Apex is so close that he took bell, not diaphragm. For other parts, he used diaphragm, which increases sound from the lung. See, here, Perfectly, it's not for the one patient or this one, but they gave you different sounds here. So, and you have to describe which place it is. Yeah, sure. Which line and which
This time,
place.
James, every time I place my stethoscope on the chest, could you say 99 for me?
As well, I can
99.
in the palpation in the percussion, we use two manners. We take our hands on the thoracic part symmetrically and ask our patient to say word 99. When you produce this voice in the inner side, it's a vibration of the lungs, and this vibration you can check by your hand in the beginning, and now he do it the same with auscultation. If in the symmetrical parts is symmetrical sound coming out, it means that vibration in the tissue of the lung or in the alveolus is symmetrical. So we can compare where which kind of liquid, solidation, or other kind of problem exists.
99. 99. 99. 99. 99. 99. 99. 99. 99.
James, if you could now sit forward for me. I'd like to examine for any glands in the neck.
You remember we do it in the head and the neck examination, so I think it's not important right now. Let's see then. I need posterior part. So from the back side, the same. We begin with examination and then chest expansion. What he will do, the same as I say, fingers towards the vertebra in the breast. See? Now he especially do it for you that one side is working, another not. He do it especially, but perfectly it must be symmetrical movement. One moment, please. When you check your patient from the backside, you ask your patient to cross hands on the thorax. Why? To open, to take scapula laterally from the bedside, to take the place for percussion and for auscultation. Playing now dulls by percussion now, see? Especially, it's not resonance.
James, I'm now going to listen to your back. If you could just keep your arms folded and breathe in and out through your mouth for me.
And auscultation, my dear. Normal breathing, resicular. Obstruction of upper ways, which gave you this wheezing. Asthma. In asthma, my dear, inspiration is shorter than expiration. In pneumonia, we have crackles mainly, and perfectly in pneumonia fibrosis.
Now, if you could say 99 for me.
Once again, 99.
99. 99. 99. 99. 99. 99. 99. 99. 99.
So, this is how we do it. Let's check once again. I want to show you lungs excursion. Somewhere I took it especially for you. Once and once again, it's very important to do it right, my dear.
All right, I'm entering the room and washing my hands. Hi, Mr. Hoffman, my name's Nancy.
Once again, yes, the same, but from different parts. So, examination always begins with dialogue with your patient.
Do you smoke cigarettes?
No.
And have you ever smoked?
No.
Do you have any history of lung problems like asthma, emphysema, bronchitis?
I have not.
Okay, all right, good. So I'm going to proceed with the assessment. First thing that I'm going to do is I'm just going to be observing and looking at the chest, and this is the inspection. So I'm first noting his respiratory rate is within normal limits. That's how fast he's breathing, and the rhythm.
You remember what I say about the respiratory breathing rate? You never say to your patients that you have to calculate it.
I see you're sitting up straight as opposed to leaning over, trying to catch your breath, and I see that the chest is symmetric. I also notice that the anterior-posterior ratio to the transverse ratio is 2 to 1, which is normal. Then I'm going to continue my inspection, also looking posteriorly at the posterior chest. Same thing, looking for any abnormalities for the shape of the chest, which is within normal limits. The chest should be shaped like a cone. All right, then I'm going to continue the assessment by palpating the chest. I'm going to touch it, and I'm going to touch the chest all over. Please let me know if you have any.
Say palpation, my dear,
areas
of the chest.
And I'm checking for anything abnormal, bumps, bruises, masses, pain, tenderness. I'm looking at the skin for anything abnormal. I'm looking at the color of the skin while I'm doing this, particularly looking for pallor, pale, or cyanosis, which would be blue. And then can you stand up for me for just a second? Turn around. And I'm going to check the expansion of the chest.
That's what I want to say once again. See?
Can you take a big breath in and out? Okay, and you see my hands move in and out. Do that one more time. In and out. Good. And so the chest expands symmetrically. Have a seat again. And then I'm going to continue with my assessment by auscultating lung sounds. So I start auscultation at the trachea. And then I want you to open your mouth and breathe a little bit deeper than normal, in and out.
He checked trachea as well by breathing. We do not do it because
And I'm going to continue listening. I listen to a full breath in each spot. And I compare side to side as I go down the chest.
see comparing both sides. Okay, I do not need all of them because we have only idea.
Okay, so just be normal for a second. Around here, and then you can lift up to listen down low. So you can listen above the bra here and below the bra across here. And then I'm going to listen on each side. So left lateral, you lift your arm up. Listen in 2 places, big breath. And again.
If you listen nothing from anterior or posterior side, we do not do it usually on the lateral sides, but by the rules you can do it.
Right laterally, we're going to listen in 3 spots.
It's more careful examination, as you see.
So on the right, there's 3 lobes, so you listen in 3 places. 1, 2, 3, like a triangle.
In the right side, we have 3 lobulus, you remember, and 2 on the right, on the left.
Starting at the very top, the APCs of the lungs come way up here. So big breath. Open your mouth and breathe in and out through your mouth.
With open mouth because bigger portion of air is going inside, so it's easier to understand.
I'm going around the scapula.
Around the scapula, my dear, on the both sides, so between the vertebra and scapula, on the intercostal space, of course, not on the bones.
One more area, the center near
Okay.
the sternum, and also in the back.
So, and the third one, which I want to show, I think here is something interesting as well. It's percussion perfectly. I especially look through all the videos I released to find something normal for you. Not every video is useful, as you remember.
Examination of the lungs. Examination of the lungs is best performed with the patient sitting down and the upper body undressed. Inspection can already yield signs for pulmonary conditions, such as a barrel chest caused by emphysema. Additional diagnostic clues include an altered respiratory rate, an imbalance between inspiration and expiration, or signs of dyspnea, such as intercostal retractions or a notable use of the accessory muscles of respiration. Now begins the percussion of the lungs. The examiner places one middle finger firmly on the patient's chest and strikes it with the middle finger of the other hand. Physiologically, the air-filled pulmonary tissue should produce a resonant sound.
See difference in the
Below the level
sounds.
of the lungs, auscultation produces a dull sound. Percussion of the lungs is always performed on both sides and should follow a predetermined pattern. The examination usually starts cranially, about a hand's width lateral to the spine, and then moves caudally, alternating between both sides. In the lower thoracic area, percussion is also conducted from medial to lateral. Dullness to percussion can indicate effusion or, for example, a tumor. In contrast, hyperresonance results from emphysema or pneumothorax. The mobility of the lungs is best assessed by first determining the transition from resonance to dullness on complete exhalation, which corresponds to the inferior border of the deflated lungs. Percussion is then repeated on maximum inspiration to find the border while the lungs are inflated. The distance between both borders determines pulmonary respiratory mobility. Unilateral dullness to percussion should always be compared to the other side to confirm the finding. Pleural effusion typically presents as dullness that rises from medial to lateral. Respiratory expansion of the thorax can be checked by palpation. During expiration, the examiner places both hands on the lateral thorax and applies mild pressure to create skin folds. On inspiration, these folds should vanish bilaterally. In case of impaired ventilation, for example in atelectasis or pneumothorax, respiratory expansion can be asymmetric. Palpation is also used to assess tactile fremitus. If the patient is asked to say the words 99 in a deep voice, mild vibrations should be felt in the lower lung segments, around the level of the 8th to 10th rib. Increased tactile fremitus, which indicates increased sound conduction, can be found in, for example, pneumonia, whereas decreased fremitus, and therefore decreased conduction, can result from pleural effusion. Closely related to tactile fremitus is bronchophony. The patient is asked to whisper 66 while the examiner auscultates the lungs. In states of increased sound conduction, the whisper is louder. If sound conduction is decreased, it is quieter or may disappear completely. The most important test when examining the lungs is auscultation, while the patient is breathing regularly and through the mouth. It follows the same pattern as percussion. Auscultation allows evaluation of the breath sounds, which can be diminished or increased, for instance. Furthermore, the ratio of inspiration to expiration time should be noted. Auscultation may also reveal other abnormal findings, such as dry or wet crackles or pleural friction rub. Breath sounds heard over normal pulmonary tissue are vesicular. Auscultation across the upper airways results in bronchial breath sounds, which have a higher pitch in comparison. Bronchial breath sounds heard over pulmonary tissue are considered pathological and hint at the presence of pneumonia. Evaluating the right middle lobe is best achieved through anterior auscultation. Therefore, if pneumonia is suspected, the lungs should always be examined from the anterior as well. Auscultation is not limited to the lungs, but should also include the trachea. Tracheal stenosis produces inspiratory stridor, which can best be heard posteriorly in the paravertebral area or anteriorly above the sternum.
Okay, my dear, you understand it. So, what else can I show you, or how else I can help you? So once again, now we speak about the thorax and everything which we have inside. Perfectly, we speak about the respiratory system, which covered by the rib cage. Beginning of examination is always visualization with your eyes, looking on the skin, shape, scales, and so on. Then palpation, then percussion, and auscultation. Does not matter which will be the first, which will be the second. What is our respiratory system? It's airways, which begins with the mouth and nose, continues by trachea, bronchi, bronchioles, and in the last portion, alveoles. Differences in the viral pneumonia and bacterial is that when I say about the COVID that interstitial swelling and press on the alveolus and make it smaller from the outer side. So bacterial pneumonia destroys inner epithelium of the alveolus inside, so and produce extra liquid which is inside. So this bubbling, ronchi, and other kind of sound exists in the lungs. Perfectly is for bacteria. Viral is always more silent, so vesicular sounds is but low pitched, low kind of. So deformation of the chest we spoke about changing in trachea size in the side of trachea, displacing of it, normal and abnormal. So we have not do on some tissues because this tissue gave us produce a specific sound which can be mistakenly taken by us. So the lungs position and the line we perfectly we have to do a symmetrical examination by the percussion and auscultation. How to produce it? What is auscultation and what is normal and abnormal sounds of it? So I think I gave you all the parts which you have to know. Only the one is the part excursion of the lung. From the back side, when ask your patient to inspire and check by percussion the part till which it is going down. See this line, my dear, the low line, and take the marker on the lungs. Then ask to expire, and once again do percussion. Changing in the sound will be above it more than 4 or 5 centimeter. This length is excursion of the lung. So normally when you expire, it's upper part. You remember it's going with the diaphragm down. In inspire, it's going down. So if it is less than 4 centimeter, we have problem with exclusion of lung. If it is more, we have hyperventilation as well. So it must be noticed in our history, patient's history. Okay, do you have any question to me? Guys? Okay. It's not easy, Sam. It's big Sam here. Something to read as well, my dear, and to understand what kind of sounds we have. So, what is normal percussion sound? What is normal auscultation sound? What is abnormal sound? Where we have to do it? These places, intercostal and costal spaces, my dear, and the lines. This must be studied by you. It will be given in your exam question. Okay? Okay, if it is everything understandable, so meet you, I think, the last hour lecture on the Tuesday. Yes, as I remember. Thank you. Goodbye.